This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
Care coordination, if we take this rising acuity level, we take the ambulatory shift into consideration, it means we have to connect the dots more intentionally, more proactively than we have in the past.
Welcome to SG2 Perspectives. I'm your host, Trevor Durin, and today I have my colleagues Chad Giese and Josh Aaker with me, who lead our cardiovascular research and forecasting team. We're going to discuss the top trends impacting CV care, the workforce, reimbursement, and of course, devices. But first, really important question for these two nice Minnesota boys. Where was Paul Bunyan born?
Trevor, that's a very easy question. Paul Bunyan was born in Bemidji, Minnesota. He's there with his babe, the blue ox. But the real question is, where is he living now? Chad?
So, well, I can answer that one, Josh. That's easy. He lives in Brainerd, Minnesota. It's the home of Paul Bunyan Land. And I visit Paul Bunyan Land with my kids just about every summer because this is near my home where I grew up. And every time we go, the 60-foot statue of Paul Bunyan still knows who we are, remembers that we are from Illinois. I kid you not.
And that's the answer.
There you go, Trevor.
That's interesting, guys. I hope this isn't a precursor of things to come, because the real answer is that it was developed as part of a marketing campaign for a logging company in California. Didn't take off for a while, and then all of a sudden, several geographies started kind of grabbing on to the Paul Bunyan legend.
No, you're wrong. No. Yeah, no, you're definitely wrong about that, Trevor. He's real.
See,
yeah, he's real.
Paul Bunyan helped make the 10,000 Great Lakes of Minnesota. That's how Babe the Blue Ox walked through Minnesota, creating all of those lakes. That's why they're there.
You know, Trevor, you can't believe everything you read or see on YouTube or television. So maybe we should just facts, maybe we can move on from here before Josh and I cry.
That's a fair way to transition. All right. So that's obviously an important takeaway. But if there's maybe two or three other things that listeners take away about the future of CV care, what should it be?
I think the top two or three things that we work with our members on a daily basis really are, first, the rising acuity level of the CV patient population. We see more and more of our CV patients having multiple comorbidities, which all lead to this more complex patient type that is presenting to our members either in the hospital, in the clinic. It doesn't matter. The patients are more complex. The second would be this shift to provide more ambulatory access for patients. The ambulatory shift of procedures is top of mind. This is driven by payers. We see disease management in the ambulatory space be a focus to prevent readmissions. So we see kind of a policy aspect here. But then it is really this just providing access across the care continuum that organizations are focused on or need to focus on more, which brings me to my third point, and it's care coordination. Care coordination, if we take this rising acuity level, we take the ambulatory shift into consideration, it means we have to connect the dots more intentionally, more proactively than we have in the past. Some of it's value-based care driven. Some of it's just the management of technology, implementation of technology across the care continuum that's driving this care coordination need.
Yeah, I think in keeping with that type of care coordination, we've often talked about in the past this shift from inpatient to outpatient. And a lot of organizations, when they're talking about that, they seem to forget in CV that oftentimes that inpatient to outpatient shift has already occurred. It just happens that it is taking place inside the hospital, that those patients that are having PCIs or ablations are staying in the hospital. They're using your high acuity resources, such as your electrophysiology lab or your cath lab, but they're still utilizing that high acuity hospital space. And so now what we're seeing is really a revolution where we're moving off campus and moving truly ambulatory. So we're going to have to connect those dots from the hospital into the truly ambulatory space. And I think what's interesting is this is being driven a lot by payers. We know that there's, for example, payment parity for ablations and the inpatient and outpatient for certain procedures. But now CMS and several other payers are really trying to move those procedures truly off campus into that ambulatory surgical space. We saw that just with the update in the new OPPS 2020 rules, allowing PCIs to be truly in that ambulatory surgery center space, which I think is really interesting and possibly something that's going to occur more and more as time goes on.
Yeah, so that inpatient to outpatient shift has largely happened over the last 10 years. Now it's that evolution to the hospital to ambulatory shift in sites of care for delivering these even cardiac procedures. Diagnostic cath, Josh, was 2018 when they added that to the ASC approved reimbursement list. PCI kind of opens this up to not just be a diagnostic only shift, but a therapeutic shift, and being able to implant a stent in a patient who has a blockage of a coronary artery in that ambulatory surgery center space. This is a big shift. This is something that our members are really grappling with. Now, there are some headwinds and tailwinds here, though. This is not an all-comers. This is not something that's going to be applicable in every market across the country. This is something that will be a specific strategy based on your market dynamics, your physician employment or physician engagement, physician relationship dynamics, and the patient acuity levels, really. If we look at what's driving out, payers are driving those procedures to the lower cost sites of care. They're certainly interested in this, is why CMS is behind it. Physicians that are independent, they're independent groups, they're interested in this because they see the dollars flowing and want to capture more of that revenue. And why not? Why not open it up in your own clinic? Why not a cath lab in your own clinic? Let's so they can reap some of that benefit too. And then even if you've got an employed physician group, so there really isn't any drive from the physician side to engage in this type of model, maybe there's a capacity issue. You've done your utilization analysis on your hospital campus cath lab and EP lab, and instead of building, because you've seen that you're at capacity for those labs and the only way to grow is to add additional labs, instead of building onto the hospital, which tends to be pretty expensive, maybe this freestanding, standalone ASC or office-based lab strategy is one that could free up capacity at a lower overall cost to build. Now, the kind of the headwinds, though, are...
Yeah, there are plenty. I think there are some key things that are slowing that shift in different markets around the U.S. And part of that, as you talked, is with these employed physicians, there's often no reason that these physicians really want to move completely off campus, make that drive every day, have to manage patients both inpatient in the hospital and then go out to these ASCs. Also, building a cath lab is quite expensive. It's not just a traditional operating room. You need to have special resources that are solely dedicated to these cath lab procedures, which can get quite expensive. One of the other things that you had brought up was the rising acuity in patients is also this rising comorbidity. So these patients are becoming more and more complex to manage. So do you really want to be moving these patients into an area where they're not going to be able to be next to an OR in case something goes wrong because they have multiple other cardiac comorbidities? They are obese, for example. They have diabetes. These are all challenges. Another key factor, I think, is really physician preference, is that they're spending a lot of time within their hospital. They have resources that they can use at the drop of a hat if they need to. But one of the major driving preventing forces of this ASC shift is the certificate of need. And for many organizations, you have to really decide, are you going to spend that certificate of need on one cath lab, or are you going to spend it on a much larger hospital or a much larger medical office space that you can use multiple different disciplines, your GIs, your ENTs? So it's really a challenge to focus on a very dedicated CV ASC compared to a multi-use, multidisciplinary facility.
One other option that particularly CMS is pushing to think about driving down cost is bundles. So what's next for BPCI Advanced?
The transition of value is a good one to weave into this conversation because it really does highlight the three most important areas. It kind of weaves them all together: rising acuity, ambulatory shift, and care coordination. It weaves them all together into a cohesive product and a cohesive patient management pathway or methodology or protocols. And we see BPCI Advanced being the stepping stone for the what's next. And the what's next is, well, there will be more of it. It will either be in the form of bundles or it will be in the form of some other risk-bearing, risk-sharing schema. And so organizations are taking the opportunity given to them in this voluntary model to kind of learn the tricks of the trade to deliver in this value-based model or methodology. What's interesting is the episodes that organizations are taking on kind of surprise us in some way, but don't in others. So let's look at the two types of initiators, episode initiators that you could sign up as. You've got physician group episode initiators, and you have high acuity or hospital-based episode initiators. The physician groups are all taking on, no surprise, the procedures, things that are more clear-cut, acute, shorter in duration. You kind of do the procedure on the patient and they go home. The hospitals are all taking on chronic diseases. They're taking on things like heart failure. Did you know, Trevor, that heart failure was the #1 episode by participation of the hospital episode initiators?
That is surprising.
It is surprising. We just talked about how the rising acuity level, the increasing comorbidities, this is the heart failure population. And organizations are actively, voluntarily choosing to take on the task of reducing utilization and improving quality for this patient population. And they're doing it in part because they're already on the hook for these patients through readmission penalties. And so I think in the back of their head, they're saying, well, if we're on the hook anyway, and we're going to have to improve the quality of care we provide these patients so they don't end up in our hospital within the next 30 days, we might as well engage in a bundle across 90 days such that if we do improve the quality of care and decrease utilization, we can share in the savings that we provide CMS. So it makes sense, but it's a big challenge. And CMS is actively looking at ways to expand this type of opportunity to save spend on these very difficult patient populations. And so I think they've really made it clear that this is not the end that we'll see in the transition of value, that we're still kind of at the beginning, and they're going to continue to add to this list. They're going to continue to promote new models as we go along here. And the mandatory nature is not out of the question for much of what we do in the bundle space.
And even beyond, in my mind, the CMS bundles, we're still seeing bundles coming from a lot of other different sources, particularly employers. We're seeing payers, major insurance companies going towards really negotiating with hospitals to craft their own bundles. So utilizing your BPCI Advanced bundles sort of as a training wheel, as a guideline to figure out what is going to work best for your hospital, your disease population, is really a great opportunity to start proactively preparing to deal with these new value-based payment systems that we're moving towards.
At the same time, earlier on, Chad mentioned the challenge of managing chronic conditions. Mm-hmm. But then I'm surprised to hear CHF is the #1 bundle. But I've heard you guys talk about how much tougher CHF is getting to manage. Josh, tell me more about that.
Well, I think it's because there was just a new study that came out of the Journal of the American Medical Association. And so there'll be a couple numbers. So just bear with me on this. A total of 80% of the heart disease deaths that occurred were in adults over the age of 65. So when we think about that, that's a huge population. We know that heart disease is the leading cause of death in Americans. But what's interesting is there was actually, on the age-adjusted mortality rate, there was a decrease of 5% of patients dying from heart disease, but there was a 20% increase of mortality for those patients with congestive heart failure. Congestive heart failure is really what is driving the heart disease that we're seeing in the patients that are coming through your system. And they are challenging both in your inpatient, your outpatient, in your ambulatory space. And one of the key things that we found in our research as we were going through some of our data is the changing demographics of the heart failure patient. There's not just one type of heart failure patient. So we talk about two major classes of heart failure patients. Heart failure patients with the preserved ejection fraction, which is when the left ventricle pushes blood out into the aorta. If that's preserved, it's going fine. The normal amount of blood is going through your body. Everything's fine. Now, the other form of heart failure is with reduced ejection fraction. So the heart is not pumping as much or as high quality blood into your body throughout your body. And in the past, we really had seen this heart failure with reduced ejection fraction, which we call HFrEF, as being the primary cause of heart failure. And there are drugs that you can use to treat them. There are procedures that we can use to manage these patients. But because of lifestyle changes, particularly, we've seen a decrease in coronary heart disease and, in what is oddly a positive note, a reduction in myocardial infarction. And so heart attacks have been going down and people have been surviving them. But because of that, that damages the heart. And so we're starting to see an increase in the rise of the HFpEF, that preserved ejection fraction. Now, these patients are extremely challenging because there's really no treatment that we're able to provide them. And one of the risk factors for this that's helping drive this is hypertension. And when we look at America, about 45% of all Americans have some form of hypertension. So this is increasing the possibility that people are going to have heart failure later in life. And I think that's really what's starting to drive why organizations are starting to think about this. But what makes them more challenging is not only that they're having other cardiovascular comorbidities and making them challenging when they're inpatient, but they also have many non-cardiovascular comorbidities. And we know that the more non-cardiovascular comorbidities they have increased lengths of stay, they have increased mortality, and they're less likely to be discharged at home. So I think that's what makes them the most challenging of the patients. And so we really need to start thinking creatively about programmatic development. So what are ways that we can prevent these patients from having to seek care inpatient? Can we think about community access points, working with your community organizations to treat hypertension? Also thinking about same day or next day access clinics for treatment to help use IV therapy to diurese these patients. I think these are where that trying to connect, again, that system of care of inpatient, outpatient, and that truly ambulatory space in that system of care is really going to help the organization better manage these particularly challenging patients. And going along with what Chad had mentioned about, bundles, we want to be able to control these costs. So can we have cheaper access points where these patients aren't seeking expensive inpatient admissions and then even more expensive readmissions?
Yeah, Trevor, this population has been a challenge for every organization that we've worked with over the last 10 or 15 years, quite honestly. Readmission penalties brought this to the forefront in 2011 when those were put into practice and into policy. This is for all of the reasons Josh has just mentioned. The changing demographics to be primarily HFpEF, which doesn't have a good treatment, the increasing in comorbidities that patients are presenting with. They're presenting and being diagnosed at a later age, so it makes them more fragile, more complex, kind of just more difficult to manage. This is going to be a challenging population for the next 10 years. So we have not solved the heart failure conundrum. We're seeing this hit inpatient length of stay going up. We're also seeing volumes between 2010 2012 and 2016, a 10% increase in heart failure admissions. Now, that we don't see that turning around, quite honestly. This is going to remain a challenge, even if we can put programs together, which you highlighted. Even if we can put programs together to manage these, it's still going to be difficult. So every member that we work with, heart failure is on their strategic plan.
And just put that 10% into perspective, that was an extra 100,000 discharges nationally. So, if you are already overburdened now, your beds are full, your ED is full, just imagine what that silver tsunami is going to be bringing in the next decade.
So on that heartwarming note, Trevor, what else do you have for us here?
Well, that's okay in general. A lot of the SG2 service line stories can get a little scary. But let's talk about structural heart. I think there's some new guidelines, maybe some new opinions about what the future could look like there.
Yeah, a little lighter topic here. We've got the CMS in, this was June of this year, June of 2019, updating the national coverage decision for transcatheter aortic valve replacement therapy. They made a couple key changes to the NCD that will expand this therapeutic option to more centers. That's at the end of the day, that's the main take home. There will be more TAVR centers opening up shop. And we've talked to a number of them who are already taking advantage of the updated guideline. We also see clinical data showing improvements in care over standard therapies like surgical valves. So I think the clinical data are more supportive than they have been in the past, and we'll get more long-term data to support the use of the transcatheter therapies as we go along here. They are still relatively new in the grand scheme of cardiac innovation. They've been around for 10 years, not 50. And so we're still relatively new here, and cardiologists require long-term data to really change their practice. But we've seen the shift towards the structural heart side of things kind of take shape fairly rapidly over the last 5 years. And then what this ultimately means is how are organizations going to manage margin and cost of these programs? We see more centers doing these. They're going to do more procedures, and they're very challenging to make a margin on because the device cost of these new innovative products are just higher. And in the case of TAVR, they're a lot higher. They take up the majority of the DRG payment. So this is going to be a challenging field. It's going to be a challenging field to remain sustainable and viable, but it's not going to go away. And we're going to have to really create these partnerships, in my mind, between the provider, the payer, and the supplier to make the whole financial paradigm work.
I think another factor with that is if you're an organization that owns multiple hospitals, you don't necessarily want all 5 of your hospitals that are clustered in the same area doing all of the same type of procedure, for example, with TAVR. And you're sort of trying to battle between these hospitals of who's going to get which volume. And so some of the societies have come together and written a really great document to think about how do we regionalize who is going to do what type of care. Particularly, for example, tier 1 centers are doing these really complex, non-traditional TAVR. They're doing work that requires both open and transcatheter procedures at the same time. Whereas your more community-based hospitals, those tier 2, are doing a very traditional TAVR. So really working together as an organization, talking about who is going to get what patient, delivering the right care at the right place. I think that's going to be really critical. I think that goes along with doing that margin management of making sure that you're utilizing those extremely high acuity resources on the patients that really need it, and then shifting the patients that can do, I don't want to say bread and butter because no TAVR procedure is bread and butter, but the more traditional TAVR at those local community hospitals.
Guys, really well said. I think some complex stuff that you were able to package really nicely. So Chad and Josh, thanks so much, and look forward to having you on SG2 Perspectives again soon.
All right. Thanks, Trevor. Thanks for having us.
Thanks, Trevor.
Thanks so much for joining us today for this episode of SG2 Perspectives, where SG2 experts and industry thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. I've been your host, Trevor Durin. Contact us anytime by sending an email to sg2perspectives@sg2.com. SG2 revolutionized demand forecasting with the Impact of Change forecast in 2001, and today we're the healthcare industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks for tuning in. Hope to see you again soon.